the 2004 guidelines that the APA published for the treatment of schizophrenia, I think underemphasized the potential value of long-acting injectable formulations. They basically said if they're really reserved for patients who demonstrated non-adherence by relapsing multiple times, and I think that's way too conservative an approach. I think once someone has already experienced relapses due to non-adherence, we've kind of lost the battle. I really believe that we want to try to prevent every relapse that we possibly can, because the relapses can be so devastating. And I'm not saying we can prevent 100% of relapses. Even when someone's receiving a long-acting injectable formulation, there still is some risk of relapse or breakthrough. But we can reduce the risk enormously, in my opinion, and we should be less conservative in the use of long-acting formulations, because there's no reason not to use them. I mean, there are no disadvantages in terms of side effects. So we should be asking ourselves, why not use them? What's the reason not to? I'm hoping that the new APA guidelines, which have not been finalized yet, will have a more proactive approach to the use of long-acting formulations. We've provided some feedback, and some of the professional societies have provided feedback to the APA regarding this issue. So I hope they're going to respond to some of the suggestions that we made, but I have not seen a final draft, so I'm not sure.
The National Council for Behavioral Health has come up with some guidelines for long-acting injection, which I really like. I have been a big fan of long-acting injection ever since I used to do NIH trials, and we would go to people's houses and they had no idea how they were supposed to take their medication, and they had bottles and bottles of stuff. And so I've been a real proponent for long-acting injection. And the council's guidelines suggest that you need to use long-acting injection earlier and more often, and that long-acting injection can make sure that the medicine is getting into the person. It can make sure that they're able to have that stable medication so that they can work on their recovery. So the council guidelines suggest using it with recent onset first episode patients. They suggest using it with anybody who prefers a long-acting, anybody who has trouble taking medication daily, which is a lot more people than I think many providers recognize. So providers have a really hard time recognizing who's adherent and who's not adherent. And I recommend, just as a national council kind of suggests, give this choice to anybody. Do you want a pill? Do you want an injection? These are the pros and cons, so that they can make a good choice about it.